Hello everyone from CRT 2020. It's a pleasure and a privilege to welcome today Dr. David Maron from Stanford University, co-chair of the ISCHEMIA Trial. So Dr. Maron, welcome to CRT 2020.
Thank you.
I know that there is most likely no one who didn't hear about the results so far of ischemia since you announced them all at AHA 2019, but could you just, for the sake of an intro at least, summarize a bit the key points and maybe just draw more attention to what are, for instance, your personal expectations, did they meet them or not, and what are the key points actually of the trial?
Sure, happy
Thank
to.
you. Thank you so much.
So the ischemia trial really grew out of the COURAGE trial, where it was demonstrated that people with significant coronary disease and some ischemia had no reduction in death or MI from PCI compared with medical therapy. And so in ischemia, we targeted patients who had at least moderate ischemia on a stress test and randomly assigned them to an invasive strategy where they underwent cath and, if feasible, revascularization and received optimal medical therapy compared with a conservative strategy of optimal medical therapy alone. Those were the initial management strategies. The primary endpoint was a composite of cardiovascular death, non-fatal MI, and hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And overall, there was, after a median of 3.2 years of follow-up, there was no statistical evidence of a difference between the strategies. Now that's kind of the main take-home point. However, there are interesting subtleties. For example, in the invasive strategy, early on, there were more MIs that were a result of the procedures that they underwent. However, during the course of the trial, there were fewer spontaneous MIs in the invasive strategy. So if you look at time to event, which is the type of analysis we did,
yeah.
There was really no difference over that period of observation in the time free of an event between the strategies. But there were more procedural MIs, as you would expect, in the invasive strategy, and there were fewer spontaneous MIs in the invasive strategy. Then, a key secondary endpoint was quality of life. And among patients who had angina at baseline, there was a clear benefit from the invasive strategy. Their quality of life improved. So
Which is actually the key. When you look at all the countries that were involved, there were over 30 countries, and on all the thousands of people that you were included, I think that eventually for all of our patients, the quality of life is something that is substantially irrelevant of the strategy that we offer them.
Absolutely. There are two reasons why we do anything in medicine, and one is to keep people alive.
Absolutely.
And two is to improve quality of life. And so while we found absolutely no mortality benefit from an invasive strategy, we found a quality of life benefit for those who had symptoms.
Actually, when one looks at the demographics of the trial, one can say kudos to ischemia because there was no ageism at all. Your median ages were all about 60, over 65, 67.
I think it was 64,
64,
I think,
yeah, which is also very good. And the more we age and the more we're treating the aging population, quality of life is definitely something they, I think, globally prefer. And maybe we're just returning back to the good old medicine of the watchful waiting, which could be also a solution. So I don't want to take more of your time, but since it's February, it's Heart Month, and it's a Heart Month for women, and we're all trying to support Go Red for Women also during CRT by wearing at least a red pin. You have also a red tie.
Red tie.
No,
okay.
we accepted all the shades of red. We were all quoting Coco Chanel saying that there is a shade of red for every woman and every gentleman, of course. So You had ischemia had something like 20% of women enrolled. What's your take on that?
Well, I think we had 23%. More women had been evaluated for randomization, but interestingly, as you may know, we did a screening coronary CT angiogram, yes, that was blinded, and more women than men were excluded because of the absence of obstructive disease. So we know that INOCA, ischemia, yes, and
exactly,
with no coronary obstruction. Is more common in women. There were fewer women who had significant ischemia on the stress tests that when we were recruiting from the various stress labs. I'm happy to say that in an ancillary study called CHOW, where we evaluated the natural history, mm-hmm, of people with ischemia with no obstructive disease, that the preponderance of participants in that study were women, because those were the ones
actually,
yeah,
that didn't meet the criteria for the other one. So finally, what would be the take-home messages in terms of what are the implications for all of us practicing on a daily basis that ischemia showed us?
Well, there are a few. One is that there's no reason to rush to the cath lab. If someone has a lot of ischemia on a stress test, but they are stable, then there's time to stop and think. If that patient has symptoms, and after being informed, for example, of the ischemia study results, that patient wants to proceed to revascularization, revascularization should be performed to improve that person's quality of life, even though there's no evidence yet of the benefit in terms of clinical
yes,
endpoints. Secondly, if a patient has no symptoms, it's hard to justify doing revascularization, and that's with the proviso that these patients would have met entry criteria. They don't have left main disease, they haven't had a recent acute coronary syndrome, their ejection fraction is not less than 35%. And we really need to think hard now about the role of stress testing, the role of stress imaging, the role of coronary CT angiography. The trial wasn't designed to figure the answers to those questions, but those are questions raised. And then what we don't know yet are what are the prognostic implications of the different types of MI, procedural versus spontaneous. I say we don't know yet, but that's really a tease. I'd like you to know that we're going to be presenting those results at the American College of Cardiology meeting in a few weeks.
Yeah. Thank you, Dr. Maron.
My pleasure.
Thank you, everyone.